What things can be done to improve global cerebral hypoperfusion? Great question. Love to know some causality there. If this is from an injury, what it's from, that helps to point out what we're going to try to do to help. But otherwise, you're just thinking about number one, is that hypoperfusion because do we have enough blood pressure? How's our heart rate doing? If those things aren't compensating, like somebody I thought I mentioned earlier, they saw like a big drop in their heart rate, like a 38. If you're having inconsistent beats like that, your pressure is going to be in these big things where you're going to have oscillatory changes, right? So that might affect your perfusion pressures. Could be that it's related to inappropriate intracranial hypertension. So we got to know what the cause is. And then once you know the cause, then you can back out what you're trying to do. So if it's something like autoregulatory failure, you go, okay, cool. I need to figure out how do I improve the sensitivity and the gain of the autoregulatory system. Okay, how do I do that? Well, I can alter the amount of pressure that is put against a cerebral artery, and I can do that in a way where I can get the artery to respond. That's pretty cool, and then we can build from there. Or I need to stabilize and get a normal CO2 response, and if I normalize the CO2 response, then the autoregulation does better. Cool. So I don't have a good answer for that would apply to everyone there, but I would tell you how I would think about it would be to try to figure out what lever I could pull that would affect it, and then to understand what lever I would pull to affect it, I would want to understand a little bit more about the causality. Cool. Do you think that gabapentin or baclofen should be good options? It's a good question. So when I think about it, if we're not able to generate enough signal to be ultimately to be inhibitory at the cord, and then ultimately we end up in these storms, then it's a function of a lowered output signal. So we're having a paucity of signal from somewhere in that system that's not getting through, and then we see the escape activity at the core level, right? So this is where we see that autonomic output goes up, we see pain sensitivity goes up, we see dystonia, or we see increased flexor reflexes, or even just regular MSRs are going to be more jumpy, right? So we know that at that cord level, we're not inhibiting the interneurons appropriately. Using baclofen might be a way to decrease the motor output so you're not seeing that escape pattern come out. So you're just like at the end organ cutting it. But if you do that, everything upstream of that is still failing. So you can stop, like if you're having dystonias that come with it, or if we're trying to just like stop the motor outputs in a moment, and where it's like we're just trying to like quickly nullify it, then I think that makes sense. On the gabapentin side, same thing, but we're just going to decrease the sensory response, which is going to then decrease the motor response. So in both cases, I would actually be looking, as long as like we're not in a seizure-related activity, I would be looking to try to get more output or increase the signal, because I want to ultimately have that summate in the cord better so we get the normal inhibitory response. So I'd be looking at things that would actually clarify the signal, make it a little bit stronger, more robust, so that it arrives down there. But I think we might also consider looking at that in two ways, because if you're in a hospital setting, you may be trying to just get it done quick and get to a nullified setting and then rebuild from there. So that might be the acute strategy, with an overlying long-term strategy where you're trying to rehabilitate that system and make it so that output's actually bigger, and then managing the acute moments with something like a baclofen. Gabapentin you might not find as useful. I don't know, but my experience with that has been that you actually, because you're looking at you're looking at escape signs like a pathological reflex, and if it's if we're changing the somatosensory inputs, then we might actually get more motor on the output. But this is a really great question. I'd be happy to talk with you more about it. I like the way you're thinking about it for sure. Rainey's asking about abnormal smooth pursuits. Have I heard of it? Oh my gosh, this is my life. For those of you that don't know, a smooth pursuit is when you're tracking an object with your eyes only, is how we measure it. But it's basically like if I'm looking at my finger I can track that with my eyes. And you'll notice that when you do that, the eyes move really smoothly to match whatever you're looking at. And you can do that kind of however it's going, right? And that's pretty cool. What that tells us is we have an accuracy of like how well the eye can detect the edges of the target and to be able to use those edges to keep our eye in the frame. I always talk about it in terms of binoculars. If anybody's ever looked through binoculars before and you're not really good at it yet, you might be watching a game and that person's running and they get over here and you're like, oh shoot, where'd they go? And you like move too far or you're off and then you come off the target. In those cases, you would have like an abnormal smooth pursuit where your eyes are jumping around trying to hold on to the target. But if that system is working very well, my eye is able to notice when I start to get to the edge of the guard. It's like the warning track in baseball. Once I get to that warning track, it shifts my eyes to move. So the same way I could like, trace something with my hand that was moving or follow a ball and catch it, I can do that with my eyes and be able to coordinate that. So errors in that coordination are very, very telling. They can tell us about where the problems are on one side of the brain versus the other. They can tell us if it's something that's happening in a horizontal plane or a vertical plane or a diagonal plane. It can tell us about the way the eyes are integrating with the vestibular system and into the parietal cortex. So they're really, really useful. Also in cerebellar activities as well. And they can help us be very diagnostic in terms of understanding how the brain's communicating. Super great test, part of a better battery. You're probably going to look at nystagmus. You're probably going to look at gaze holding in different planes where you're just trying to hold your eyes steady. You're going to look at pursuits and comparing horizontal to vertical. You're going to look at saccades, which are the fast eye movements where it's not I'm tracking something, but it's like, oh, something popped up over here. I'm going to take a look at that. And it's how accurate are you at being able to hit those? Can you do it with timing? Can you do it with speed? And then we'll usually also look at things like optokinetics, where we will see with visual motion, how well does your brain do at maintaining that reflex? We'll look at reaction times. We'll look at how well your subjective vertical is. Like when you try to take a line and make it vertical with nothing else to see as a reference frame, how well do you do at that? And that tells us a little bit about your inner ear as well. And then we'll look at things like VORs, where a VOR, or vestibulo-ocular reflex, is kind of like the mirror image of the smooth pursuit, because now the object is still, but my head is moving. But the mechanism's kind of the same, where my retina helps me detect where the object is, and I want to match my eye speed to my head speed in that reflex. So it's kind of like one, your head is still and your eyes are moving, and one, your eyes are still and your head is moving. And then if we want to get real good, we can look at what happens when I'm trying to coordinate my eyes and head moving at the same time or in opposite directions to understand how those things coordinate on a deeper level. So remember, everyone, that these autonomic problems that we're talking about are motor problems. So these are movement disorders. And so if you think about Tourette's is a movement disorder where we have this disconnect between sensory inputs and motor outputs, and we end up with an error signal. The error signal of Tourette's is going to be related to some different things, right? So it's going to be related to some inputs about different environmental cues that may trigger that, and different mental tasking cues, different contexts that will yield that extra response. And you can think about similar things in autonomic world where the typical contexts that people talk about are kind of smaller. Orthostasis, feeling scared or fearful, feeling surprised, feeling anxious, those things can all be triggers. Hunger, full stomach, different stimuli in the sensory system, whether it's visual or vestibular or somatosensory or, with the proprioceptive system and whatnot. So all of these are different contexts that can yield an autonomic motor problem. And then we might see that overlap with what we see with the motor problem relative to tics. And you want to find out, is there a place where those two things overlap one another?